Chairman, ladies and gentlemen, good afternoon, and thank you very much for the opportunity to come and present this afternoon. As Chairman says, my name is Matthew Giles. I'm an acute physician and geriatrician from Oxford, and the slide here is just to remind me and just to illustrate to you that Oxford is a very beautiful university city, which is historic and ancient in lots of ways, which happens to have a slightly less historic and a slightly less picturesque hospital just up the hill from it. So that's a little bit about Oxford while I get my electronics to work. So, as I say, thank you very much to the organisers and to the committee for inviting me to come and present today. In terms of acknowledgements and disclosures, it's a great pleasure to be in Sri Lanka. I've not come to Sri Lanka before. I've been lucky enough to work with some exceptionally talented Sri Lankan physicians and trainees, so it's wonderful to see where they come from. Also, in terms of acknowledgements, some part of what I will talk about is based on work by my colleagues, and that's Professor Pendlebury and Dr. Lovett, who spent a long time preparing a data set which I will talk about as we go along. And lastly, I don't have any relevant conflicts of interest. So, in terms of delirium, it's a concept or it's a condition which has been recognized for a very long time. So there are very eloquent descriptions in ancient Greek literature describing people who are delirious, and indeed the term delirium is derived from the Greek. But more recently, in terms of our day-to-day ward work, I think one would all be very familiar with being called on call to see a patient, an elderly man who's brandishing his walking stick, and he's insisting on leaving the ward even though he's being treated for a community-acquired pneumonia. And we're all familiar with seeing again on our ward rounds an elderly lady who's a bit withdrawn in the corner of the ward, who's been in hospital for some time, and she's failing to engage with the physiotherapists or the other therapists who are trying to help her get better. And again, these are two very clear examples of patients who would have delirium. My personal experience, and just to talk about a case, just to illustrate what we were talking about, is a 42-year-old female doctor who 2 days post-operatively, after incision and drainage of an abscess, over the course of the day, she develops very rapid onset and very striking changes in her concentration and awareness, and she's hyper-aware, she's very anxious, she's worried that there are burglars next door who are going to break into the house, and she's very agitated. And again, the important thing to say is that that was my wife a couple of years ago after an operation, and it was very striking that we were quite slow in recognizing that she had a delirium. It was very scary for her. I was quite alarmed as well, and we'll go on to Mrs. Giles a bit later during the talk. So what is a delirium? Delirium, according to the DSM, or the American Diagnostic Statistical Manual, requires 4 things. And essentially, it's based on identification of a disturbance of consciousness, and that is altered states of awareness or changes in your sleep cycle. It requires a change in cognition, and that is either a memory deficit or a language deficit, or problems with hallucinations or delusions. And it requires that comes on either acutely and then fluctuates in terms of its course, and has got an underlying medical cause. So that's the standard definition of a delirium. So in practical terms, in terms of our day-to-day clinical management, how do we recognize this condition? Well, we need to identify a problem with inattention. So a patient is very distractible. Problems sometimes associated with cognitive level, with conscious level, and a disturbance in cognition, as I say, in terms of their thinking, their language, and their memory. And the important things to say is that delirium has a very variable clinical course over time. So even though that when we do our ward rounds in the morning and we see a patient who appears sensible and cognizant, that doesn't necessarily exclude delirium, because it might be that that patient later on in the day or in the evening is agitated. So we can't just take a single snapshot to exclude a diagnosis of delirium. And so it often needs for us to take information from multiple sources, i.e. speaking to the nurses on the ward, speaking to a patient's relatives, to identify whether or not a patient's course is fluctuating over the period of hours or days. Importantly, there isn't a single diagnostic test that we can do. So going back to Professor Bell's talk, it requires our clinical skills and acumen to diagnose. And also it's important to recognize, as well as hyperactive delirium, which is usually the agitated, mobile, cross patient, we should also recognize hypoactive delirium, which is a patient who's a bit sleepy, a bit withdrawn, and not quite right, or in the UK, we use a slightly awful term, which is off legs. I hope you don't use that here. Do you? Okay. So that's what delirium is. How frequent is it, or how common is it? Well, it depends a little bit on where you look and how hard you look. But essentially, the settings in which you will see figures quoted are in the ITU or in the intensive care unit, where delirium is commonest, also post-operatively settings, but the rough, the approximate numbers on the medical wards, certainly from Europe and then North America, is of the order of 20 or 30% in medical admissions. But as I say, it depends a little bit on how you look and what tools that you use. So moving on to an Oxford data set that I made reference to a little bit earlier on, this is a study which I was involved in, where we looked at over 500 consecutive admissions to our medical wards. So these are all patients who are coming in, unselected medical patients, and they were screened on admission, and a collateral history was taken from relatives to look, as I say, for the diagnosis of delirium. And this figure down here shows our age categories on the x-axis and the number of patients on the y-axis. And the white bars show the overall number of admissions. And for your interest, the modal age, which is this tallest line, is 86 to 90. So those are that's the most frequent age of admission. But and there are very few young people who end up on the acute medical wards in Oxford. But the more important aspect, and what's relevant to this talk, is the black bars, which show the numbers of patients with delirium. And as I say, the distribution is highest in the elderly, and at its highest is of the order of 40% in, as I say, this is in consecutive medical admissions. So just putting some numbers to that, the rates of delirium, certainly on our wards, are of the order of 30 to 40% in the elderly population. And in our practice, the elderly population is usually over 65 and certainly over 75. So that's how frequent it is on our wards in Oxford. So that's how frequent delirium is. Next is to think about what causes it. And again, it's a balance of how considerable an insult or a medical condition is and the vulnerability of a patient to delirium. And what it's quite nice when you're teaching the medical students, when you're quizzing them about causes of delirium, what's quite nice is that actually all medical conditions can cause delirium. So you're asking your medical students a question which it's impossible for them to get wrong. So they might say, well, Dr. Giles, it's an ingrowing toenail maybe, and you can congratulate them and you can say, yes, great, you've got the answer right. And it's very nice to always give such a nice question to medical students. But thinking about things slightly more scientifically, you can classify causes of delirium in terms of acute brain insults, and I've listed the commonest here in terms of metabolic abnormalities, energy deprivation, trauma, and stroke, and then in slightly smaller brackets, post-seizure activity, primary CNS infections, or brain cancer. But the commonest causes of delirium are non-brain associated or non-direct brain associated. And again, the commonest cause in my practice is infection, and the commonest source of infection is community-acquired pneumonia or urinary tract infection. But again, any source of infection can be a very potent cause of delirium. Drugs are very important, and we'll talk about that in a second. But less well-recognized causes, and again, causes which I would ask you to be very vigilant of on your wards, are pain, dehydration, and urinary or fecal problems, particularly constipation or urinary retention. And as I say, those are the most frequent causes of delirium, certainly in my clinical practice. Going back to drugs, again, as I alluded to earlier, the list of drugs that can cause delirium is as long as your arm and probably longer, and so I've listed the main offenders here. And again, in our practice, the commonest are opiates or analgesics, anxiolytics and hypnotics, anti-Parkinson's disease drugs, and alcohol. And alcohol is always important to remember, both in terms of acute intoxication and withdrawal. And again, that's the patient who becomes delirious and agitated 2 or 3 days into their admission, and nobody's quite considered the fact that they're drinkers at home and they've stopped drinking and now they're withdrawing from alcohol. And going back to our case, going back to Mrs. Giles, whose permission I have to talk about her, the cause of her delirium was that she was in pain. Although she had had a drainage of her abscess, she was still septic. She was on tramadol, which is an opiate analgesic, which is particularly associated with delirium. And she was also constipated. So she ticked all of the boxes for causes of delirium. So next, thinking about going from the degree of the insult to the degree of vulnerability. So who is it who develops delirium? These are data from the Oxford cohort that I mentioned before. So this is consecutive admissions to a medical ward. And these factors which we identified are essentially those which identify frailty, both physical and cognitive. So that was increasing age was associated with increasing rates of delirium. Any prior CNS illness, be it dementia or previous stroke or other neurodegenerative problems, physical frailty in terms of being admitted from a care home or care institution or needing care before you came in, and also pressure sore risk is a marker of a physical frailty and usually being underweight and sarcopenic. And for those who are interested in mnemonics, you can develop quite a nice mnemonic to help you remember all these causes, which is sundowners. And again, you can have a look at that in your own time. So that's thinking a little bit about what causes it, and it wouldn't be unexpected to say that the pathophysiology, given that there is such a broad range of causes, is actually very complicated and multifactorial. and I'm not a neuroscientist, but I can explain that it's a combination of inflammatory processes and cytokines working through a number of neurotransmitters, which essentially causes an increase in dopaminergic neurotransmitters and a reduction in acetylcholine neurotransmitters with an endpoint of delirium. So thinking about what to do on the wards, there's a simple tool which we use in Oxford and is recommended by our national clinical guidelines and bodies, which is the CAM tool, or the confusion assessment method, which is a simple bedside tool which requires the physician to identify an acute onset and fluctuating course in mental state associated with inattention, and also to look for disorganized thinking and or an altered conscious level. And for the CAM, in order to make a diagnosis of delirium, you need both 1 and 2, and then either 3 or 4 in order to make a diagnosis of delirium. And again, that's an example of a simple bedside test which the trainee doctors can use. It's important to think about differentiating delirium from dementia, because that's a frequent factor, a frequent part of the differential diagnosis. And I think that the most important aspects are delirium has a sudden onset or a more acute onset than dementia, and follows a fluctuating course. And patients with dementia, often their attention is maintained. So at the bedside, you can have a prolonged conversation often with patients with dementia, which, although the conversation doesn't make any sense, they will speak to you and chat to you very happily and very charmingly, whereas the same is not true for patients with delirium. And also, hallucinations and delusions are more common in patients with a delirium as well. But it's important to recognize about the hypo and hyperactive states which delirium can be associated with. So having recognized it, what do we do? There's always a question about whether or not you pursue a sort of a more neurological based investigation for patients with delirium. And actually, certainly our UK guidelines is that actually you don't necessarily need to do brain imaging, EEG or lumbar puncture, and these investigations should be reserved for patients in whom primary CNS pathology is indicated. So in terms of management, I think the most important aspect of management is being aware and suspicious of the diagnosis. So it requires swift recognition and then treatment of the underlying cause. Additional factors would be avoidance of iatrogenic harm or insults, and be that catheterization, frequent venipuncture, and so on. Be very judicious in the treatment of constipation and making sure that patients aren't in pain, making sure that patients are adequately hydrated and fed. And then there's more soft aspects of the management, which can be classed as non-pharmacological or nursing aspects. And I think it's very important to be very reassuring to patients and to explain to them about what's going on. And as I said, it can be profoundly worrying both for the patient and for their families. So engagement of the patient's family is also very important. Ward environments are very important as well, trying to reduce or avoid overstimulation, and that is noisy monitors, lots of people at the bedside coming to and fro, and also trying to establish a regular sleep-wake pattern. And if all of that fails, then pharmacological intervention is the next step, although one must be at pains to point out that that should be avoided if one possibly can. And the indications for pharmacological intervention would be considerable distress, risky behaviour in terms of from the patient or agitation, and the choices are usually between an antipsychotic and benzodiazepines, and whether or not one gives the treatment either parenterally or intravenously or intramuscularly. And certainly in Oxford, our standard practice is to use an antipsychotic as first line, and the decision is slightly split between using haloperidol and olanzapine. Of note, the evidence base for pharmacological treatment is really very limited. In terms of outcome, I think going back to the Oxford data, the outcome from delirium is poor, both in terms of what happens to the patient during their admission and thereafter. And it's important to say that the rates of ongoing urinary or fecal incontinence are increased. At discharge, patients need more care, and the risk of death is also increased. And just to illustrate this, these are the data from our Oxford cohort showing death over the course of time, and it's with the dark line at the top being those with delirium and the lighter line at the bottom those being without. And it's important just to demonstrate, which I'm trying to do with my little pointer, that the rates of delirium is associated with a very much higher rate of death, especially in the acute phase. I'm going to just rush over my next slide or two. There's a question about whether or not delirium is associated with an increased rate of dementia, and whether or not the presence of delirium can trigger the onset of dementia or a worsening, and there are data to support that. So just to conclude, delirium is a common condition. It's important to be aware of in terms of our bedside practice, to look for problems with altered mental state and inattention. It can be fluctuating, so you've got to look serially or ask people who are aware of it over time. It's got a very broad differential diagnosis and is associated with a bad outcome, so please suspect it and treat it. Thank you very much.